So I want to welcome everyone. This is our March Cup of Tea event. I'm hosting the event today. My name is Ivana Rostevsky, and the Cup of Tea is an event that's intended to bring the Canadian retinoblastoma community together for an informal discussion about research, a research article. The discussions center around articles which members of our Canadian Retinoblastoma Research Advisory Board, or CRAB, have created plain language summaries for. So what we will cover today will be some announcements from the Canadian Retinoblastoma Research Advisory Board and opportunities to participate in future events, a cup of tea update, then we will discuss the article summary and have the opportunity for community discussion. So for our announcements, I want to encourage everyone. I do see most of you who have joined us so far are in our retinoblastoma research community. The research community was created to connect people who are personally or professionally connected to retinoblastoma and are interested in research. Anybody who's listening or watching our video after our live presentation, you can go on our website, rbcanadaresearch.com, and there'll be an opportunity to join on the bar at the top of the screen. And anybody who's already in the community, I encourage you all to share information about the retinoblastoma research community with patients, their families, and colleagues who would be interested in connecting with us. So any events or the cup of tea presentations that we're doing quarterly can be found on our YouTube and Spotify channel under the name Retinoblastoma Research. You could also follow us on social media for news not only about the cup of tea, but other events and patient engagement opportunities on RB_research on X, at RB_research on Instagram, and at RB Research on Facebook. Any opportunities to partner in research that I would like to share are I'm looking for our next cup of tea partner. Our June 2025 theme is long-term treatment side effects. So I need a patient partner or a family member and a health professional who can partner together and present on this topic. And I can share more information offline. Anybody who's interested can send an email to retinoblastoma.research@sickkids.ca, and we can connect that way. I also want to share information about joining the Patient Advocate Committee, or the PAC, of the Rare Pediatric Eye Cancer, or the RPEC Biobank. And again, more information about that can be received through our email, retinoblastoma.research@sickkids.ca. Upcoming events, the most recent upcoming event would be the virtual RB Community Symposium. There was some change of plans with the symposium now being fully virtual on one day, April 5th at 11 Eastern Time. You can register at rbsociety.ca/events. I also found an interesting piece of information from our OPAC friends. They have scholarships now available. There's a deadline that's upcoming on April 30th, and anybody who wants to know more about scholarships can find information at opac.org. That's opacc.org / OPAC scholarships. Our future cup of teas will be the next one on June 17th, the September one with the topic of the biobank in September 16th, and then wrapping up the year will be in December with the topic of new treatments on December 16th. So for today's cup of tea, we will be discussing the article Digital Retinoblastoma Documentation Supports Care and Research. The plain language summary of this article is available on our website, rbcanadaresearch.com. And the one item we wanted to point out with this article is most of the authors here are not just authors who helped write this article, they helped develop the DEPICT Health program, which we'll be talking about. So the instrumental role that many of these authors played is just important to recognize. But I don't want to spend too much time because we have a lot to cover. I want to welcome our presenters tonight. We have Cathy Johnson, who's a mom to Sarah, who was diagnosed with bilateral retinoblastoma as an infant and became a longtime CRAB member. Cathy has attended many events and partnered on research projects. She's one of our most regular cup of tea attendees. And Cathy has worked in IT, but is now interested in learning about ancient Egypt. Interesting fact. Our health professional presenter is Breanda Gallie, who's an ophthalmologist and designer of DEPICT Health. Breanda met her first RB patient, SickKids emergency in 1973. And patient one has inspired her life's work in retinoblastoma with her focus on record keeping for RB patients, which continues to evolve. So Cathy, I will pass on to you to continue and share your story and the article.
Thanks very much, Ivana. My personal experience with RB began 42 years ago yesterday, actually, when my daughter Sarah was diagnosed with bilateral retinoblastoma at the age of 11 months. Her left eye was enucleated and her right eye was successfully treated at Toronto SickKids with a combination of cryocoagulation, radiation, and chemotherapy. We felt very fortunate to be living in Waterloo, Ontario at the time, just a short distance from Doctors Gallie and Chan and the SickKids Eye Clinic. Before she died in 2021, Sarah expressed the desire to establish a fund to support novel research and action towards a better future for RB survivors, which we did with Brenda's help and also Helen, I think. So, and if I've forgotten anybody else's names, I apologize. But for more information about the fund, you can find on rbcanada.research.com under About Us. Go to In Memoriam and you'll find a blog post that has information about the fund and more stuff about Sarah as well. When I first heard about DEPICT, which is the main subject of the paper I summarized for today, I was struck immediately with its enormous potential to address Sarah's determination to support long-term follow-up care and information for all RV patients and survivors. Bits and pieces of her medical history were scattered in numerous locations in and outside Canada, but all on paper. So when she was diagnosed in 2016 with a second primary cancer while living in the US, she had really enormous delays accessing any records at all concerning her RB treatment as a kid at SickKids Hospital. So in reading this paper, I hope to find the answers to these questions. First of all, how has retinoblastoma record keeping evolved in the past 40 years plus? How will treatment and follow-up be improved for patients and survivors? And how will research be facilitated? This next slide, it's sort of more of a placeholder for you. These are two unique novel terms introduced in the paper, and I just want to note them now, but I'll describe them in detail when they come up in the context of the presentation. So, to understand the importance of DEPICT's innovative approach to digital RB documentation, I thought it would be helpful to start with a little bit of history. So, first of all, the invention of the indirect ophthalmoscope occurred in 1947. For the first time, it was possible to examine the entire retina, not just the forward-facing surface, and accurately diagram the size and location of all RB tumors. So I'm going to turn it over to Breanda, who can give a much better description than I can of exactly how it functions.
Well, many of you have experienced the indirect ophthalmoscope yourselves. Ivana, click. So here is a baby down here in the corner. I think, can you see it? Oh, it's not quite on the whole computer, is it? Anyway, yes, there, that's better. It's a matter, it's my computer. The light is shining into the child's eye, the left eye, and you can see just hidden on the right eye, there's actually leukocoria, but the tumors in the left eye through the large dark pupil, you can only best see with the indirect ophthalmoscope. And the light goes from the indirect through the hand lens held there in yellow, and then shines and is aimed at the tumors in the back of the eye. The light then comes from the retina and goes back to the examiner's two eyes. And because the light's going to two eyes, there's actually depth perception. So if there's a seed floating in this eye down here, you can actually tell where it is, and you get 3D view of the inside of the eye with the indirect ophthalmoscope. And the next one, the images from the two eyes are just images, but then the brain of the person has to interpret that and put it on a paper drawing since the 1950s, and draw with colored pencils and show everything. And the reason this instrument is so important in retinoblastoma is the first time that the whole retina could be examined. Previously, the most you could see with the direct ophthalmoscope was just the back of the eye, and they would think everything looked fine there, but then the tumor in the edge of the eye that was not visible would grow unannounced.
Thanks, Brenda. Just before we move on, I'd like to add that there's many textbook explanations of how the indirect ophthalmoscope works, but I'm willing to bet that unless you've gone trick-or-treating at Halloween at Brenda's place, you've never seen such a unique explanation, which is courtesy of the queen of all our hearts, if I could say. Okay. In the period between 1973 and 2021, as Brenda mentioned before, colored pencils were used to draw the RB tumors on a standard paper form, which is in fact still used today in RB centers throughout the world. So each EUA had to make a new drawing, and these were all stored in a paper file called the red chart and stored in the eye clinic in a filing cabinet. So you can imagine that as time went on and the number of RB patients increased, physical storage and access to patient history during the EUA created challenges galore. In the year 2000, the database ECCRB, which is eCancer Care RB, was designed, implemented so that retinal drawings were digitized or in digital format, and associated treatment timelines were generated so that the records were all available on a computer. And between 1973, or patients' red charts who were at the clinic between 1973 and 2000, key drawings from their red charts were actually also added to ECCRB along with treatment events that on their corresponding timelines. And the way it was recorded is two bars, or like two graphs. And I think the one on top, if I'm not mistaken, is the right eye, and the one below is the left eye.
That's correct.
Okay, great. So once everything was digitized, then red charts and paper drawings were discontinued, and everybody heaved a major sigh of relief, I'm sure. And another advantage is that it was much quicker for ophthalmologists to refer to drawings and treatment history during EUAs. If changes were observed in the retinal diagram, it could just be, you could call up the previous drawing, make the little changes, and save it, and you wouldn't have to draw from scratch every time you did an EUA. Records for all the RB patients at SickKids were now accessible electronically. And another important thing is that the visualization of this data contributes to patient and family understanding of the disease stage at diagnosis, in addition to treatments and possible outcomes. And from the researcher perspective, they had a large and ever-growing pool of retrospective data for study. So that little path down memory lane now brings us to today. We're soon to be released is the next generation of digital retinoblastoma documentation. Due because of outdated ECCRB software and hardware infrastructure and advances in IT. So soon to be released is DEPICT Health, which we'll call DEPICT from now on. And it's going to be hosted on secure cloud-based technologies. And it's supported by the International Retinoblastoma Consortium, which is a charitable organization run by volunteers committed to enhancing RB patient care and research. And it's not directly affiliated with an academic or medical institution. It's strictly volunteers. The main idea of this paper is to introduce DEPICT as the next generation of record keeping. It will offer digital RB care and full view only access for families as partners in retinoblastoma care, wherever they are in the world. It presents retinoblastoma specific data such as drawings, timeline, research support, and clinical consultation to the entire circle of care of each patient, who gives permission for to share their DEPICT data with using this communication service. So it's really important to note it's the patient who controls access to this data ultimately, and clinical team would enter data at each appointment. Optionally, a patient can also give consent for anonymous research use of their DEPICT data for research requests from the clinical team or ethics board approved research. So it's really important to emphasize the fact that if a patient decides to or gives consent for their data to be shared for research purposes, all personal identifiers are stripped, and so they remain completely anonymous as far as the research is concerned. So the previous two slides have given you an overview of the architecture of DEPICT. So we'll now watch a video that was prepared by Caitlin Flagg to demonstrate how DEPICT is used by the members of the Circle of Care.
During this portion of the presentation, we had a video demonstration to show the ease of use of DEPICT Health for both the family and the clinical team. This demonstration showed how easy it is to use DEPICT due to the easy to navigate interface and the unique timeline view of appointments and procedures. As a parent or patient, all information is at your fingertips, including control over who has access to the tool. You can add people such as pediatricians and ocularists, and you control who sees your information, and you can also remove them when you're ready to do so. The medical team of the partner hospital already has access and editing capabilities. They update the tool in real time. Looking at past events is also easy with the unique timeline of treatment, which clearly shows treatments per each eye and includes details such as images and fundus drawings. The tool is easy to use for the clinical team as well. Forms take just a few clicks to complete, and the status is easy to see. Form approvals are instantaneous, so when you have a parent sitting next to you, they will receive the form as soon as you sign off, and vice versa. To learn more about DEPICT Health, which is provided by the IRBC, visit https://bit.ly/IRBC1. DEPICT Health is supported by the International Retinoblastoma Consortium, a charitable organization run by volunteers committed to enhancing retinoblastoma patient care and research. The International Retinoblastoma Consortium is not directly affiliated with an academic or medical institution.
As a physician working in a site, I can sign as my part, but not for the site.
That's there is no signature for the site. There's only a signature for the there's one communication consent form that would be needed for all members in that site to use DEPICT Health, and that form is signed by the patient, of course, and then by a designated representative of that hospital. So at your site, you very well might be the signing authority for everybody at your hospital to have permission to use that patient's DEPICT Health account.
But
Okay.
but also the institution, the site, has to have a legal agreement with DEPICT Health, with the International Retinoblastoma Consortium.
This is what I mean, yeah.
Yes, so BC Children would need to sign on
Yeah.
the same form, that every site would have the same form, except it would have different logos and things like that for each site. And they have to have that contract first before anybody at that institution can be in DEPICT Health. And we think the first one will be Alberta, because there's two major hospitals treating retinoblastoma in Alberta, but they're all in one health system, the Alberta Health Services. So that's one agreement, one model deal between the International Retinoblastoma Consortium and one site, which is all of Alberta. The rest of the provinces have their individual hospitals and around the world. Yeah.
That's a great question, and we'll have some more questions posed.
Yeah, so on that point, can I ask another question or leave it to the end?
Go ahead.
Yeah, so the question here is that is the IRBC, the consortium approaches the sites, or the reverse, the site approaches the consortium if wants to use it?
I think we're open to either model. So we're just getting ready to, we've approached Alberta Children's Hospital and are working with the Hospital for Sick Children, and are both in early stages of starting those conversations, but we anticipate other sites will start reaching out anxiously to be part of this, and we'd be happy to receive those inquiries and to work with whomever is interested.
Thank you.
Thank you for those questions. We will have more questions discussing the DEPICT coming up, but our next piece of information will be shared by Cathy. You can continue, please.
Okay, thanks very much for that wonderful demo, Caitlin. Actually, I think you explained everything so clearly during the demo. I don't really need to add anything to it. It's basically showing what a patient timeline looks like in DEPICT. So unless you have questions, I won't bother adding it to that. I'll just go on with the next slide, please. Okay, this paper discusses the results for two ongoing studies using the DEPICT approach for RB research. And this is where I mentioned at the beginning there are two key terms to understand. The first one is swimmer RB, because results or findings of the studies are presented in the form of swimmer RB plots. So basically what swimmer RB is, it's a graphical view to compare multiple RB patients simultaneously. And for clinical research, each study participant, which is like a horizontal bar in this graph, or can also be thought of as a swimmer lane in a swimming pool. So the first study that's discussed is called ocular or eye survival, and 2 years after triple versus single drug IAC, which is intraarterial chemotherapy. So first thing to note is that the conventions used in swimmer RP are shown in this swimmer plot, which is showing DEPICT data. They use the same conventions as ECCRB, that is symbols with different colors or shapes indicating different anti-cancer treatments on the timeline. You'll see that. Thanks for pointing that out. And In addition, color coding can also be used to differentiate specific study groups. You'll see here, there's bars of two different colors. There's 23 bars above it, enclosed in a green rectangle, peach colored, and that represents all the study patients who received triple agent IAC. Below, in the red rectangle with gray bars, are 13 study participants who received single agent IAC. So the swimmer plot is showing that by counting the number of enucleations, which is those yellow triangles, in each study group, the green and the red, 2 years along the timeline post-treatment, eye survival was 80% for those receiving the triple drug IAC, whereas it was only 54% for those receiving the single drug IAC. Okay. The second concept that's helpful for the understanding of this paper is a novel definition. It's called consequence score. It's a way of ranking long-term severity of RB treatments. You'll see from the table on the right-hand side, each possible treatment is assigned arbitrarily for now as a first instance or a first approximation, a consequence score, and they get bigger as you go down the list. So the lowest is focal, and the highest is either EBRT, I believe is external beam radiation therapy, or enucleation of only eye, have a consequence score of 30. Next, please. We can go, okay, thanks. The second study presented in the paper is, it's showing some initial or preliminary chemoplaque clinical trial data. So first of all, if you're like me and you didn't know what a chemoplaque was because you were in the eye clinic so many years ago, it's a small disc holding radioactive beads surgically placed directly on one eye or on eye for several days to decrease the size of the retinoblastoma tumors. So in this plot, you'll see that, again, there are two rectangles, one red and one green. So the red one shows the 1 year period immediately prior to the beginning of the application of chemoplaque, which is time point 0. And in the green, that's a 1 year period immediately following the chemoplaque treatment. And how this data was analyzed and grouped and the results presented is using within each rectangle, either before or after chemoplaque, for each study participant, they took all of the symbols there, colored symbols which correspond to different treatments, and added up their corresponding consequence scores. So there were two, one for pre-treatment and one for post-treatment. And results from this study indicate that for the 27 subjects of the study, 17 showed a complete response. You see on the right-hand side of the graph, there's a lot of green CRs. The way you know that it's a complete response is that if you look along the swimmer lane for that particular patient, there's absolutely no treatments after the chemoplaque was administered, which corresponds to a consequence score of 0, no severity at all after the chemoplaque. And within 3 years after the completion of the chemoplaque application, no further treatment was required for 63% or 17 of the participants in the study. The other thing to note about this study is that at the top of each rectangle, you'll see those are an analysis of the significance of the accumulative consequence scores pre and post treatment, and they are applying statistical tests. They've been shown to be statistically significant. I mean, you can, even just by eyeballing this, no pun intended, you look on the right-hand side and you see hardly any colored icons for treatments there. All you see is a pile, well, a large number of CRs for complete response. So I think, to me, it just demonstrates beautifully the significance of the adage, a picture is 1,000 words, because I can just imagine as a researcher how much easier it would be to see your data analyzed and presented in this format rather than having to scan through piles and piles of columns of data on piles and piles of pages before arriving at a similar result. So there you are.
Kathy, could I just comment that the chemoplaque is not radioactive? It contains topotecan chemotherapy, and it stays in that study, it stays on the eye for 42 days.
Oh, thank you, because I guess I just relied on Google and expected it was telling me the truth, but maybe it was a general. Thank you for that clarification. That's good that you. Okay.
Can I ask a question?
Sure.
Do you have a software that can create the swimmer RB image yet, or it has to be created individually, like according to adding one patient timeline by a time? It's a fabulous tool, and I want to show you even what I did with your IAC swimmer diagram. I did one to separate only the unilateral patients. So I did work on this one, but I want to know if there is a tool or a software that you can enter patient data, or even in DEPICT to create this image.
So I'll answer that. The last author of the paper, Isabella Yanisanic, was a summer student, undergraduate summer student, and she looked at DEPICT timelines and said, you know, I could put those all in one Excel file so that they would be compared. That's the swimmer plot. She invented that in her summer student. And whenever I went in and made a new entry into the swimmer plot, I would break it and it wouldn't work any longer. And I would send the broken file to Isabella, who then became a medical student. And within a couple of hours, she'd send it back to me fixed. Now we have a really brilliant clinical research person working with us who's taken it further and keeps it going and has many different kinds of swimmer plots coming out comparing anything we want. So it isn't quite an automated tool yet, but I believe once DEPICT is rolling, then this will become one of the research tools that will be attached to DEPICT. But that's a dream today. Thanks, Sammy.
Yeah, what swimmer stands for. Is it an acronym?
No, swimmer is a standard clinical trial technique to compare different patients. So that's people who are doing clinical trials understand these are swimmer plots, but they don't understand the way we view it with how we're using it. We've moved that concept further, but we didn't invent the swimmer as a statistical tool.
My understanding is that's why you added the RB at the end to
right.
distinguish it from the standard statistical analysis tool.
Yep. So some other disease could add swimmer breast cancer or something like that if they wanted to.
Fantastic discussions here. I just want to highlight that we're just about 10 minutes left, and I want to let Cathy wrap up her last slide before we open up the questions for everyone. After this slide, I would like to just let Caitlin do a note about the video that was presented, and then the questions will be open. So Cathy, if you would like to finish your presentation with this slide, and then we'll do questions.
I think, you know, just it's pretty obvious that the deployment of DEPICT will benefit all the participants in the circle of care, like on the parents, patients, and guardians. They can access their entire history of RB treatment, no matter where they are in the world. And also, because secondary sites will be can potentially be involved, there's reduced costs for treatment because travel and accommodation in Toronto is not going to necessarily be required if you can be treated at the nearest RB treatment center instead. And from the ophthalmologist and researcher point of view, there's this ever expanding pool of data, which now could be expanded to worldwide data, not just Toronto or Canada based. There's detailed RB treatment records that provide lots of opportunity for learning. Individual treatments and timing can be compared using swimmer RB. So there's the potential for developing better treatments, more timely results, and earlier detection of second cancers. So it's win-win for everybody, in my opinion.
Caitlin, if I can invite you to share any comments you have about the video.
Yeah,
if you
thanks,
need any
Ivana. Yeah, I just
further
wanted to add a
explanations.
caveat that I should have added at the beginning of the video, a very important caveat, which is that the patients that were characterized were not real. They were entirely fake. And as were the clinicians, I did use Ashwin's likeness, but he and SickKids have not agreed in any way, shape, or form to be part of DEPICT Health yet. Neither has Alberta. And so I just wanted to make sure that was abundantly clear. That was entirely meant to be a demo of artificial circumstance that's not yet come to light. So yeah.
Thank you. So we have 10 minutes left here. I'd like to open it up for questions. We have listed some questions that together with Cathy and Breanda, we have come up with that you could think about and help answer. And in the meantime, Cathy, if nobody's jumping in right now, I'm sorry if I had stopped the flow of the questions that were so great prior. Okay. You could share some of yours that you had about DEPICT.
Okay, well, I can start the ball rolling with a few for Breanda then. What's the timeline for deployment of DEPICT Health?
Well, that's very exciting because it's really Caitlin who has done a huge amount of work on working all the bugs out of the secure access software, which isn't part of DEPICT. DEPICT is actually owned by the UHN, where we invented it, and some of the authors on this paper are still working there and still help with that sort of thing. But that's just the database. Before it can go live, it has to have a secure way with today's standards for security to log in, and that's what's just about bug-free. I think Caitlin could comment on that, and we anticipate, Caitlin, that we need the legal agreements, and then what's your timeline, Caitlin?
No, that's right. So we're in the last final round of kind of beta testing with the software developers, which I hope will conclude this month, if not next month. And then we've started the legal agreements at Alberta Children's Hospital. I don't know exactly how long those will take, but I think we're within a matter of hopefully, certainly this calendar year and hopefully sooner than the end of year, just depending on those legal considerations that are sometimes time consuming. But yes, we're excited to get started.
There is a group, a coalition called C17 of all the pediatric cancer hospitals across Canada who all work together in multiple projects. And we haven't really brought this to them yet, but possibly it will become much easier for each hospital to join if C17 helps us, so that we could dream that it will go quite quickly all across Canada. And then, of course, our favorite sites that have worked with us from the very beginning, like Kenya, and where they actually used eCancer Care in Kenya. And then we would get calls in the middle of the night, Justin, who was built it, and me and Helen Damaris, and say, it's not working. And then we would discover that there'd been a power failure and no one turned the server on. So that was when we realized we can't move forward globally one site at a time. It has to become on the cloud to work for the world.
Is there anybody from the audience who has a question, or shall I carry on with my little list?
I have a comment. So
Sure.
I think no physician or patient would disagree that, like that DEPICT is a very great resource to help and push clinical care forward. My concern is mainly the approval of the different institutes for the utility of it, so to use it, and of course the legal part and the data ownership with the research. I think also this would raise a lot of questions. I would suggest that there must be like a somebody from DEPICT to speak with the legal team or whoever will be in charge in different institutes to uh, like convince or to show how it is safe to use it, because it would push patient care a lot, but we can't use it like off label. So yeah.
I think all that's true, Sammy, but I think the most powerful group to push their institutions so that the legal people understand DEPICT will be patients. So recruit all of you to follow Cathy's very good description of how important it is for patients to have something like this, particularly for retinoblastoma, which is a lifelong disease.
Can I ask a question?
I ask Samreen? Oh, did Lindsay's
Yes.
going to?
Yeah.
Certainly.
My question was just, how do you push this out to the patients? Like, yeah, like how do you, like you just said, like, to get the parents or the patients, how do you make contact with them to even, get them signed up and get them into DEPICT Health when that time comes?
I think that we haven't worked out the protocol for that. We need help to do that. But I think it will be that the clinicians will show it to the patients, but we'll make it quite a formal thing so that we go through it the same way. But
Yeah.
if anyone, Lindsay, would you like to help and be on that committee to design the process for implementation? That would be wonderful.
Yeah, maybe.
Good. We'll sign you up.
Right.
Another question along those lines is, how will patients access their data? Can they sit at home on their PC or their phone and just log in, or do they have to be in a special setting to get access, like a clinic, for instance?
The demo for DEPICT, when it was running, it's not running now because it's all being put into this secure space and everything right now. But
Okay.
I could log into it from a coffee shop anywhere in the world, anywhere you could, and it worked perfectly. It worked really, really well, the demo, and that will be exactly the same for this. You'll have your own logins and things. You'll have all that only you can do that. The viewer, whoever's authorized, but that will be easy to get to. And you can do it on your cell phone. I hope I can sometimes on a trek in Africa, the sheep herder will be watching his cell phone because his family is in the hospital having their EUAs and watching DEPICT as they're at work.
Wonderful. This applies to both patients and the circle of care, but also to researchers. Is there any training required to use DEPICT Health as a tool, or?
In the demo, use of the demo, it's dead easy. Now and then as Sammy pointed out, for example, the swimmer plot and the various research tools that have come out really because of the chemoplaque. We invented a whole lot of new ways to score research. Those we haven't even touched this, and we won't until this is running. We haven't got the strength to add that to it, but to have those very automatic kind of, as you won't need to manually fill out the timeless swimmer lines. They will be pulled out with a tool, but that tool hasn't been automated yet.
Dr. Gallie, you had a question for Samreen, or you had a conversation.
Yeah. So Maureen, are you still there?
Yes, I am.
Good, good. I was just wondering how this presentation worked for you. We talked all these.
Excellent. I was able to follow it along really well. The audio from Caitlin's presentation, the recorded one, I had to strain a little bit, but I guess I could access the recording of this session. Maybe the audio is clear, like better and in the recording or something, because I had my computer volume turned up, but it's still a little difficult to hear. But other than that little technical point, everything else was really easy to follow. Thank you.
Good. So this will be on YouTube and wherever else, Ivana, and people we hope can all watch it and spread it around. And then
Absolutely, you'll be on YouTube and Spotify. And I will double check when I'm saving the recordings, and I'll listen to the section with a video playing, see if I can do anything on my end to help amplify that sound. But thank you for that feedback.
I found I could turn it up on my computer manually, and it got much better. Yeah.
Well, that wraps up our time here tonight. I think perhaps one last note I wanted to share was I spoke with an adult survivor talking about how all her records were saved with her mom, who had passed away, and she had felt at one point that she doesn't know all her records anymore and her history very well because that stayed with her mom, and now it's all kind of in pieces at the centers that she was treated. So that made me think about her when we were talking about DEPICT. And it also made me think of another family I had talked with who had meticulous records collected in a nice binder, and not just of their treatments, but other experiences tied to the retinoblastoma journey that they thought was very well kept. And just the differences, I think I fall a little bit closer to the first story, where I might not really have all the right details that I would like to have, and I didn't really think about it at the time to keep a very good files. But having something that travels with you, that's very easy to see and easy to understand at your fingertips, and to show doctors that you're trying to work with about any concerns that you might be having, is very, very useful. Speaking as a parent, and I think a lot of others would agree to that. So I want to just end by saying, Cathy, thank you for presenting this information very well and very clearly, and Breanda for being a fantastic partner to helping us understand all the information here and sharing it with our community. Thank you both so much for this presentation.
Well, thank you, Ivana, as well. And thank you, Breanda, because I didn't do it without help, that's for sure.
Well, I think this cup of tea will be very powerful to take to the hospitals who are reluctant to embrace it. It's hard to argue with the patient, the strong, wonderful patients and parents.
You're here. Well,
thank you. So I will be seeing everyone again in June. Again, reach us on retinoblastoma.research@sickkids.ca if you're interested in partnering on plain language summaries and presenting on future cup of teas. So everybody have a great evening, and I will see you then.